virtual meeting. I'm Toby Everett, I'm the president of IPSS. I'm delighted to see so many people have joined. This COVID time is certainly a time for firsts, and this is definitely the first time that I've addressed so many people without wearing any trousers. The conference will comprise a 30-minute business meeting and then a one-hour keynote panel of leading simulation educators discussing simulation in this extraordinary time of global pandemic. At no point will I be standing up. As an attendee, you've been placed on listen-only mode throughout the business meeting and the panel discussion. You can submit comments and questions through the chat or Q&A feature. The button for these are at the bottom center of your Zoom window. Questions will be moderated by an IPSS staff member and brought forward at the appropriate moment. I recommend you take note of whether you're sending your message to the panelists only or to all the attendees and the panelists. It was our intention to keep the business meeting brief, a bare bones meeting, before moving on to the exciting content from our panelists. It was and is important that we met, albeit virtually, not only to sustain the momentum of society projects and advance society business that marches on regardless of the coronavirus, but also because the strength of society is in our community. We're best when we're together. I won't be the first to use the expression coming together while staying apart. I'd like to extend my personal thanks and enormous appreciation for all that you are doing to advance simulation, medical education, and the enhanced healthcare and safety of pediatric patients worldwide. Please mark your calendars with the dates for the in-person meeting in St. Petersburg in Florida on October 23rd to the 26th of this year. What a lovely treat that will be to meet you all in person when we're all released from this house arrest. Now, that said, we acknowledge the uncertainty of the forward look in this new era through which we're working. And rest assured, we're monitoring the evolving situations and projections, and we'll continue to make well-informed and responsible decisions as the sands continue to shift. I'll let you scan the business meeting agenda shown here, and we'll be keeping strictly to time in order to give full airtime to the panelists. I'd like to extend my sincere thanks to the IPSS Executive Committee you see here for their voluntary and tireless efforts and hours advancing society matters, rewarded only by the knowledge that we all care passionately about pediatric simulation. Similarly, the Board of Directors, visible here, have consistently and conscientiously offered their expertise and wisdom in the consideration of society business over this last year. A consistent theme running through 2019 is response to member feedback. We want you to know that we heard you. Finances, accessibility, interprofessionalism, global reach have all received our attention this year. We reduced non-physician fees, we introduced free membership for low and middle income countries, and reduced registration costs for the same. We formed a finance committee and introduced the role of treasurer-elect to allow organizational memory and seamless transition of officers, focusing on finances. We strengthened our relationship with nursing groups and allied professional groups. We have non-MDs in several prominent roles. And of course, our new president is the first non-MD president in the history of the society. IPSS is dedicated to pediatric and perinatal healthcare providers and organizations using simulation-based education to improve care and safety for children. Our goals include empowerment of the global pediatric simulation community, creation of a community of practice for innovation in education, research, and advocacy, promotion of patient safety and team improvements, networking and disseminating of information about best practices and novel discoveries, complement or enhance the work of other societies, and champion solutions for resource-limited environments. Consistent with our mission, the board has focused on these areas: member value, visibility, educational content delivery. I want to commend the efforts of the board this year as we have grown membership 59% since 2018 and expanded the proportion of nurse and allied health. While this is excellent news, we are not complacent and continue to look for opportunities to meet these objectives. There's been a tremendous amount of work this year, and I'll touch on a few highlights. The Bylaws Committee has completed their revisions of the original IPSS bylaws. Please watch out for a request this summer to review and vote on the proposed changes. Following a successful inaugural year, we launched the second year of the IPSS Inspire Pediatric Simulation Fellowship, with more submissions and fellows than last year. We introduced reduced or zero cost options for low and middle income countries. Please spread the word about this. We need to continue to grow our membership worldwide and ensure all of our colleagues have access to our inclusive community. COVID-19 response. We have actively engaged our community forum and are regularly providing responses related to COVID-19 and how we are adjusting to this new environment. Please be part of the conversation and share your experiences. The scenario library is extended and improved. We have hosted 7 webinars this year to over 280 attendees. In collaboration with our executive staff, we've worked on the back ends to improve our policies, procedures, and governance processes. We have strengthened the operations of the board and committees, have defined success metrics for the society and the conference. Further, we've established the groundwork for more strategic activity in the coming year. There are still plenty of opportunities for involvement. The Education Committee is populating an expert speakers bureau. They're also creating a core curriculum outline to implement an IPSSW roadshow. We're launching a new IPSS blog where members can contribute content for publication on the IPSS website. We've developed a new institutional partnership program as a way to engage with sim centers and institutions who wish to contribute to IPSS outside of conference time. And finally, we're thrilled to announce that we'll be holding IPSSW 2021 in Lisbon, Portugal. Listed here are the committees that collectively advance the mission of the Society. Enormous thanks to the chairs and the co-chairs and the members of these. The committees are open to new members, and I would strongly encourage you to contact the email shown in the chat section right now to volunteer for one of these positions. One of the committees that deserves special mention is the Meeting Organizing Committee, which has been working hard to develop the fabulous program that we can now look forward to in October. I also want to recognize our ex officios and crucially our executive office staff from Wellington, especially our executive director, Monica Evans-Loom, without whom none of this would be possible. I can't recognize everyone individually here today. Please watch out for follow-up articles recognizing those who contribute, the amazing work they're doing, and how you can get involved. We'll be issuing a call for committee members next month. We'd like to take a moment to recognize and thank all of our affiliates and patron organizations shown here. I also wanted to extend a welcome to healthysimulation.com as our first and new media partner. Finally, a recognition to all of you without whom the Society could not be what it is. Please continue to engage and encourage your colleagues and networks to join our community. Okay, that's enough for me. I'd like to welcome Dr. Michael Seropian, IPSS Treasurer, for his report. Michael.
Me? Yes, hopefully. All right. So welcome everybody. It's been a pleasure and an honor to serve as treasurer for the last 4 years. My term is coming up. So can we move to the next slide, please? So there's a variety of different things that I'd like to quickly sort of review with you and with the membership that are really important to take into account. So really to start, last year, from a financial perspective, we underperformed in the sense of registration, as well as not being able to sort of offset the lack of registration compared to expenses. And you can sort of see in this specific slide where our net revenue, okay, essentially was 100, and for registration anyways, was 193,897, which represents 64.93% of the budget, okay? And this is really important just to sort of remember that number, all right, since registration is our single biggest revenue source. Next slide. In terms of revenue, the majority of our revenue is not a surprise, mainly conference, and with 10% coming from membership, the other elements are minor or less of an importance. Next slide. I'm going through this quickly because I don't have a whole lot of So this is actually sort of an important one to really pay attention to. All right, if you recall I think it was the 69, 67% that we actually spoke about in terms of, the percent to budget of, income, actual to budget. So here we see the expenses were 88.2% of budget. Okay, and so there's obviously a significant delta there, which, next slide. The vast majority of the expenses, really relate to, again, a whole host of different, elements, related to, conference, putting on a conference, everything from food and beverage, to the space itself, speaker expenses, AV, et cetera. Next. This is the one that really sort of speaks to the delta that we actually, I'm really referring to. If you again recall, so the 69 or 67%, percent of budget versus 88% of budget in terms of expenses, and that's why we actually fell, quite a bit short of what our expected revenue or net income would be, and we came out, on the plus side of almost $20,000. Don't have it in front of me exactly what the budgeted amount was. However, it was, certainly closer to $40,000 or $50,000. Next. Okay, this is sort of gives you an idea of what's going on with the society and sort of a good lead into the next point. So to begin with, our total loss, from 2018 to 2020. 2018, we actually had a negative, so deficit, so net income of negative 27, and in 2019, a positive of 20,000. So the good news is that's actually a swing of about $47,000. The unfortunate news is that leaves us at negative 7K approximately in terms of year where we are right now essentially. Okay, from a projected perspective, if all had remained as is and COVID had not existed, we would have, we had projected a $58,000 net income for 2020. Now, this is where we sort of have to have, sort of a little bit of speculation, admittedly. And as treasurer, it's my job to be conservative. So I say that with a smile. But there are a lot of unknowns. And so the reality is that the meeting wisely was moved, to October, in the context that no one really knew what was sort of going on, and we were able to do that at no cost. Having said that, the price point for the hotel where we have a contract remains the same as it was before. And so therein sort of lies our risk. So many people are in, stay at home sort of situations. Revenues are down in hospitals. Pay cuts are happening. I can certainly speak to my own hospital. I personally have experienced a 20% decrease in my pay. The opportunity for CME, et cetera, all that stuff basically has decreased. And so the reliance on institutional funds is going to certainly decrease, and we're going to rely more on individuals, reaching into their own pockets. Having said that, may actually impact different groups in different ways. That's a long way of saying essentially that I do believe that the 58,000, while it'd be wonderful, I would, certainly consider that it's going to be significantly lower than that, since registration will likely be lower. Again, we can only cross our fingers. One of the things that we've put in place as a mitigation strategy is we've asked at Wellington to negotiate with the hotel, since currently I do believe a force majeure is still in place, and essentially the ability to change of contract so our exposure is diminished, there is always a possibility of canceling the meeting altogether in October should conditions really not change, a second wave, whatever might happen. There are a lot of unknowns right now, that basically are playing into this decision process, and we're going to be looking at things extremely closely. Next slide. I think that might be, is that the last one? Yeah, so that's the last one. Like I said, it's been an honor to serve, and you know, we'll sort of see how this things go forward this year. Everybody just needs to keep in mind this is a situation none of us have experienced, and just for us to be able to leave somewhat unscathed would be really a true bonus. Thank you.
Lovely, thank you, Michael. And a great summary, and tempestuous waters. We've certainly choppy waters to come also. There's that part of me that's the unsuppressible optimist that hopes that I look forward to seeing us all at the face-to-face meeting in October. And as such, that is the plan. As we said already, we'll continue to monitor the situation carefully and employ some sensible decision making, and for sure that no one can predict the future, has a reliable crystal ball, but I'm looking forward to the next face-to-face, and fingers crossed that will still be in Florida in October. So without further ado, I'm going to move on to the transition of leadership, and I'm going to say we'll just glancing over to see if there are any accumulated questions. There are not at this stage. So excuse me. Yeah. So next, I'd like to introduce you to our new president, elected in these spring elections just passed. I'm delighted to welcome Lydia Lofton. Lydia is a pediatric intensive care nurse by background and works in London, England. She has a master's degree in clinical education from King's College London, and she's the workforce transformation lead at Health Education England, based in London. In this role, she leads London's simulation networks and development of a system-level strategy for healthcare-based simulation across the whole of the city. Lydia has been a member of the IPSS Board of Directors for 4 years and served as co-chair of IPSSW 2018 in Amsterdam. Lydia, thank you for all that you've done for the society and for all that you no doubt will do. Over to you.
Thank you so much, Toby. I'm really honoured and excited to be taking forward this responsibility. I'd now like to announce the results of the 2020 Board of Directors and Executive Committee elections. So we're pleased to announce that Robbie Hales was elected President-elect. Betsy Hunt has been elected as Secretary, and as indicated last year, Lillian Sue has been appointed to the Treasurer position. This will make up our Executive Committee, along with Toby Everett as past President, Monica Evans-Lum as Executive Director, and me as President. We're also welcoming Anne Ades, Ellen Deutsch, and Justin Jeffers as newly elected directors. Joe Hegarty will be serving a second term, and you can see all of our board members here for 2020. For the trainee position, we're thrilled to have Kang Key, newly elected, and Michael Wagner serving a second term. Please welcome them all with me. We're really looking forward to working with you. I'd also like to acknowledge and thank our outgoing board members. Kim Stein, as past president, is now moving into an ex officio role. Rakshay Shetty has provided a valuable viewpoint and voice from our members in India. They have both left a lasting impression on this board and will be missed, but I don't think that they will get very far without us being in contact with them. So if we just move forward to thinking about the year ahead, I want to start by thanking you all for prioritizing this gathering today. I know that I'm not the only one who's been living a very different life to my normal over the past several weeks. During this global emergency, you've all been contributing to the response using your essential skills, whether that be caring for patients or educating those who are. Personally, I've felt immense pressure and uncertainty, and I'm sure that you have too. While preparing for today, I felt that I needed to share some of my reflections on my recent personal experience. I know that these reflections influence the lens through which I see how IPSS will contribute to and lead the global pediatric simulation community over the next year. 5 weeks ago, I was drafted in with a multi-professional group of 8 educationalists and clinicians to create and implement a training program for staff who would be working in a new field hospital. This field hospital was being set up to help manage the adult critical care surge, which was predicted from COVID-19 in London. The hospital was in the process of being set up within a huge exhibition space in East London, and the mission was to provide urgent critical care capacity by transferring ventilated adult patients with COVID-19 from other London hospitals when they reach capacity. There were many unknowns. While the hospital was being built, the operational model was being planned. We didn't know how many of the potential 4,000 beds would be needed. We didn't know exactly who we would be training, and there wasn't even a space identified yet in order to train staff. What we did know was that to cope with this predicted surge in critical care demand and to save lives, there would be a requirement to train staff to work with a significantly higher patient to staff ratio. The skills of the team would need to be more flexible, and they would need to quickly adapt to working within a new model of care. People with no healthcare experience would need to be trained in safety critical skills, while healthcare professionals with various specialist backgrounds needed to learn skills to support critical care specialists. Our small team had to quickly grow in order to achieve the goal of being ready to train staff within days. This team came from many different professional backgrounds and organizations from across the city and the UK. And we've learned so much from each other over this short period of time. This was certainly my first and quite possibly my only experience working alongside the military in a command and control structure. We had to bring together a large group of people on board to ensure that the demand could be met. And this group now includes psychologists, communications experts, volunteer coordinators, and others, along with the usual multi-professional mix of clinical educators. The contribution and richness of working across interprofessional boundaries has been effective and rewarding. The simulation community has been amazingly responsive. Faculty and equipment have been flowing freely from academic institutions, hospitals, and industry partners in order to ensure that we meet that required goal of preparing a workforce to care for patients during this emergency. So on the next slide, you'll see some photos of, initial photos of the field hospital as it was being set up prior to the admission of patients. And then the training space, which we eventually secured in that first week in order to deliver training in a very big arena. So the team began delivering training just after a week from our, just under a week from our first meeting, several days before the hospital opened to its first patient. Originally, the training packages that we designed with our collective work as imagined brains, they were designed for a hospital environment that did not yet exist. So we're now able to refine and continually adapt the skills and simulation program to ensure that it reflects work as done and to be able to be responsive to any safety incidents in the intensive care unit. Over the past 4 weeks, there have been over 1,800 people trained to work in this new hospital. Bedside team members have all participated in team-based simulations prior to starting work. Many of these people have not previously had access to simulation-based education and the learning experience that it can provide. If you'd asked me 3 months ago whether this was all possible, then I would certainly have said no. In such a short period of time, I've learned so much about harnessing the collective expertise of a large group of individuals, all from different professional, cultural backgrounds and perspectives. What I've learned is that when you do this, you can achieve things for patients that previously seemed unimaginable. I was reading an article this morning about compassionate leadership, which described some aspects of the situation that our worldwide community has faced during COVID-19 to date. It articulated the fact that no country has all the resources to deal with this crisis in the way that they would wish. This is uncomfortable. I've certainly found it uncomfortable. But this discomfort and this pressure has caused me to adapt in ways that previously I've not had to. So if we move forward to thinking about the year ahead, I'd really like to consider some areas that align with our strategy to move forward with action. I've seen that you as clinicians, educators, and others working in pediatrics across the world have found creative ways to respond to this crisis. As the International Pediatric Simulation Society, our community, we can grow and become even stronger within this context. Finding the right solutions for the challenges we face is difficult. We need to draw on all of our resources, especially our people, and use that collective intelligence, experience, and knowledge to adapt as things continue to change. These are the goals which I would really like to see us collectively meet in the coming year. I believe that we can continue as a society and the members within its society to lead development and use of adaptive mechanisms for education in a post-COVID state. We need to make sure that we build and sustain our IPSS community while we are apart physically. We will create and implement a strategy to ensure that IPSS leadership reflects its membership, which is multi-professional and international. And we must continue to work to improve diversity within our membership. We have opportunities to find connections within our IPSS community, to grow and to bring others on board during this time where we're physically apart. Being a member of this community is valuable, and ensuring all views are heard enables a shared focus on our goals, providing an avenue for both collective learning and innovation. As we anticipate the year ahead, I hope that these goals are shared amongst our community and that we will move forward with reaching them despite uncertain times. Ultimately, growth toward these goals will support the IPSS mission and vision to inspire, grow, and lead the global pediatric simulation community and to achieve the best healthcare for children and families. I look forward to the formal Board of Directors virtual retreat next month so that we can begin working together to see what this new normal will look like and to determine how we take things forward. We want to ensure that we meet these goals together with you, our community. We're now coming to the end of the business meeting, and I'd like to find out whether there are any questions which have been posted in the chat box or the chat room that need to be answered at this time. While we're waiting to find that out, we have some information on a survey, which you may have had some information about previously. So I'd really like to encourage you to complete this collaborative survey, which is being led by Inspire, Network Kinder Simulation, and IPSS, to learn about how institutions are training for COVID while continuing non-COVID related content during the pandemic. The outcomes and learning from this survey will support the global simulation community during this time and in the future. You can capture the QR code here, or you can visit the link which is posted in the chat function during the webinar. I think I've seen that link go up already. The link will also be sent in the coming days by the IPSS team through your email. I'll just go back to find out whether there are any questions that need to be answered related to the business meeting before we move on to the next phase of this virtual meeting.
Lydia, we had one question around considering some tiered virtual registration options and what that might look like for probably October as well as future, if you want to speak to that.
course. So it's really important that we're considering all the different ways that our members can receive benefit from being part of this membership. And I think this, this crisis that we're in will certainly allow us and ask us to consider different ways of being connected. So while we have historically talked about different methods of allowing people to attend our meetings, I think this is probably an opportunity to promote that even further. So that's certainly something that we'll discuss at our board retreat and as part of our continued considerations and conversations about October, that will be factored in. So thank you for the question. Are there any other questions, Monica, that need to be answered now?
That was the only one.
Great. Well, thank you so much. I would now like to turn things over to Brittany Dahlin and the rest of the meeting organizing committee, who will introduce today's keynote guest panel of leaders in simulation, who will be discussing the use of simulation during the pandemic.
Thank you, Lydia. Hi, everyone. My name is Brittany Dahlin. I am a clinical education specialist in simulation at Children's Minnesota, and I am here today to moderate today's panel discussion. We're excited to have 4 longtime supporters of IPSS here with us today for our panel. Our panelists are going to provide insight into their experiences over the last couple of months and how they have had to shift their work in simulation during a pandemic. If you could each take a moment to briefly introduce yourself, and we'll welcome you.
Hey, I am Tensing Ma. I'm a pediatric intensivist, co-chair for our resuscitation committee and medical director for our simulation program at Nationwide Children's in Columbus, Ohio. I have a particular interest in using simulation for patient safety and systems improvement.
Hi, I'm Jennifer Reed. Clinically, I'm a pediatric emergency medicine physician. I'm also the associate medical director for the simulation program at Seattle Children's Hospital. And like Tensing and many others of you, I love systems integration and simulation. So working with different teams to maximize the tools, teams, processes, environments that help us to provide care for children.
Hi, everyone. I'm Stephanie Sudakoff. I am also a pediatric intensivist, and I am the director of simulation at Yale New Haven Health System in Connecticut, which is a pretty large health system. It's about close to 30,000 employees, and we have 5 hospitals across the state of Connecticut with a couple thousand ambulatory sites as well.
Hi, everyone. Lennox Wong here. I'm a pediatric intensivist at Sick Kids, a longtime simulation enthusiast, and the chief medical officer here at the Hospital for Sick Children in Toronto. And past history of involvement with bridging simulation and the design of physical spaces, testing of procedures, of equipment, of policies, really with a systems focus.
Great, thank you all for being here today with us. I'm going to start with a question to the whole panel. What are sim centers or simulationists doing beyond traditional sims to prepare and help during this pandemic?
All right, is it my turn? All right, so I would start by saying that here in Seattle, we have really been focusing on the hospital's front line. So getting the ED, the inpatients, the ICU units really ready to take care of whatever might come. You know, since the first COVID patient appeared in the US and was hospitalized about 20 miles north of us at the end of January, we've really been using simulation to transform how we provide healthcare. So like many of you around the world, we have refined different resuscitation team structures, dividing our ED and our code blue teams into inside and outside teams that use telemedicine to communicate. We've developed different intubation practices, thanks in part to a lot of work done all around the world by colleagues, especially at Sick Kids, who've shared their resources with us. So we now have a very fancy clear plastic garbage bag solution for making drapes to decrease aerosolization. And we've also been thinking about how we can use different physical spaces. So I think, like a lot of you, we were concerned about the limitations of our physical space, but unlike Lydia, we didn't have quite the same resources for creating a pop-up physical space. Fortunately, because business was down, party tents were available. So we had the opportunity to set up party tents in our parking lot, and then figure out how to turn those into a place we could care for kids when they didn't have any data, didn't have any electricity, didn't have any water, and didn't have any reliable communication.
So I can say from my perspective, the short answer is basically anything anyone needed at any given moment in time. And I will also say that I've been asked to do some things I can't ever imagine I thought I would be asked to do, but have been happy to be able to provide support whenever it was feasible. So we have been asked to help some engineering students figure out whether a device they created to split ventilators would work. And it actually did. It was pretty amazing. You can actually ventilate 2 patients, 1 ventilator with very different pressures and volumes, which was something they like figured out in 2 weeks because someone asked them to, which was pretty amazing to be a part of that. We've done a lot of work with our supply chain colleagues trying to figure out how to get what PPE where, personal protective equipment where, how to change our donning and doffing protocols on an almost daily basis based on what was available that day. Some of the folks at Yale have done some really amazing work around reprocessing of personal protective equipment, including some of the facial respirators. And so there's a whole supply chain side of that. We've been asked to do just-in-time training for urologists to go be the central line team, you know, to help set up drive-through swab and testing stations and figure out how, you know, workflow is gonna go through there. Pretty much, you name it. But, you know, I think it felt very satisfying that people came to us and made those requests, and that they, you know, they had the confidence that somehow we would be able to help. And in most cases, thankfully, we've been able to at least provide some solutions, even if not an ideal one.
I think one of the things that I've observed is that it's challenged a simulationist to think about changes in dogma and changes in the way we might have originally thought about simulation. So if you think back, for those of us who've been in it for a little while, one of the original thoughts was simulation is really preparing for rare, infrequent events. And it's actually incredible because now you've got a rare, infrequent event that's affecting every single second of your life. It's the challenge then is, so how do you use simulation to shift all sorts of practices for what's happening right now, and then what's happening tomorrow, and then what's happening the day after that? So similar to what Stephanie was saying, you know, how can simulation help in the design of an assessment center that needs to pop up as of, you know, 24 hours from now? How can simulation help us with getting people to prepare for screening other people? How can simulation prepare us for learning and disseminating practices in an environment that doesn't allow close physical contact? And so it's really fascinating to see how the pace of work has changed. And I think we're going to come out of this with a lot of questions that'll be fodder and food for thought for the years to come.
I don't have much additional to add, since you guys did such a nice job covering everything. I will say one strength I think that our SIM program was able to add was that since we work with providers all across the hospital, we already have a lot of connections. And so we were then able to be that connector between groups. So, you know, like anesthesia is doing this over here and the ER is doing this over there. Let's work together and collaborate. So.
Great, thank you all. Those are amazing ways to kick our discussion off. I'd like to pose another question to you, Jen. You talked a little bit about the initial pivot you guys have had to make. Can you walk us through kind of the nuts and bolts of COVID-related SIMS, what you see as the biggest differences, and do you find you're focusing more on preparedness or on the clinical management?
You know, I was thinking about this after, one of our earlier conversations, and I was trying to figure out a way to sum up in a couple words what actually feels different about what we're doing, because to be honest, so much of what I'm doing is actually the same. I'm trying to help maximize systems. I'm trying to help train people. But I think what is really different has been the feeling. And if I had to sum it up into 2 words, and I think this matched both things that I've heard from Tenzing just now, as well as Lydia earlier, so I'm feeling pretty good about this. The words would be intense and uncomfortable. When I think about intensity, I think back to like 10 years ago. And I had this great idea that, we should have a hospital-wide, pre-intubation checklist that we use everywhere outside the ORs. No problem. Took out the one from residency, dusted it off, thought we'd be good to go. Well, as is probably familiar to many of you, 3 months later, 10 different meetings and a lot of no's, my resolve was crushed and I just walked away from that. After about 3 years, I would sort of forget the initial pain and the cycle would repeat. Nonetheless, we never got a pre-intubation checklist. But then with COVID, all of a sudden the intensity changed. And with that, we were able to do things we'd never done before. We created an 8 a.m. huddle every morning. We had representatives from all the stakeholder groups, including, I think, some that you guys mentioned earlier, like supply chain and anesthesia techs and sterile processing, people that we normally would not have been able to engage that readily. And we were able to work at it, every day for like 2 weeks. We had working sessions, we had sim testing sessions, and eventually got to the point where we really did have a whole hospital-wide rollout of a new COVID intubation plan, which included that elusive checklist. So intense.
Awesome, great summary. Yes, intense is a good word to sum up everything people have shared so far. Tenzing, I have another question for you. How has your hospital utilized SIM to make sure that they're prepared in case of an outbreak? As a standalone pediatric hospital, are you conducting many adult-focused SIMs?
Yeah, so I think most people have already covered some of this material, but mostly for systems testing, clinical environment testing, we have a special pathogens unit that went up about 2 years ago. It's been functioning as a regular inpatient ward up until now, but now all of our COVID positive patients are hospitalized there. So they may be floor status or they may require ICU level care. So then, compared to our PICU, that physical room layout is different, the staffing model is different, the equipment that's available, the medications that are immediately available are all different. So just in situ simulations to test that space, look for risks, and also evaluate our preparedness for handling emergencies there. So looking at roles of staff, both what did they do inside the room and outside the room, what equipment and supplies are needed inside the room versus outside. Is there enough PPE available, all the different cappers and other things that you might need. And then there are some COVID specific processes that we prepared for. So again, intubation being one, and resuscitation, where there are some changes to our usual procedures, as well as new process flows. So we were super fortunate to learn from other institutions what had worked for them, and what we wanted to do was look and see if those solutions would translate to our institution. So we then used simulation to vet any of those proposed changes to make sure that that work is imagined is how work should be done at our institution. So we were able to continue to refine those processes, personalize it for us before rollout to the rest of the staff, because as people were mentioning before, this is just so much uncertainty, and I think frustration sometimes when plans and everything is changing daily, weekly. So for us, it was really this balancing act of let's hurry up and get everyone prepared with let's not rush too much that we put out education that needs to be then updated the next week. So that was some of the things that we've done to prepare. As for adults in our hospital, so we do have a fair number of adult emergencies, even though we are a standalone children's hospital. And that's because they are our employees and visitors. So this is a different challenge now because they usually go down in like public places like the cafeteria or the lobby and the hallway, and not conveniently in an inpatient setting where there's lots of PPE available. So I think a lot of people have made this a similar change where they are having their code team bring PPE with them to these codes so that they can manage these emergencies in public places. So.
Great, thank you, Tenzing. Stephanie, I'd like to go to you. How is COVID-19 different from previous pandemics and epidemics that you've been involved with, and how are you navigating the SIM leadership across a health system?
Yeah, and so as I thought about it, I've had the experience of being present for lots of disasters of various kinds in my career. I think when I was a medical student in New York City, it was the height of the HIV/AIDS epidemic. And that also sort of carried forward into my residency and fellowship when we still had a pretty large number of children suffering from complications of HIV. I've gone through SARS and MERS and H1N1. I was working at Bellevue on 9/11. And then most recently going through the Ebola preparations for our organization a few years back. And as I really thought about our current situation, it feels very different to me. And I'm gonna, the word I'm using is the same word that Jen shared, which is the intensity of this is just so different. Every aspect of our current situation is so much more fueled than any I've experienced before. If you think about the sheer volume of patients coming in, bigger numbers than I have seen in the past, the duration, this has been going on for a couple of months and we've got at least another month ahead of us and who knows what's coming after that. And just this feeling that there's nowhere to hide, there's nowhere to go. They're basically, unless you want to go to Antarctica, there's nowhere to go where there aren't cases. And I have never encountered this heightened level of fear for personal health and safety in any of the past situations. Even in the midst of HIV, I didn't feel that same sort of constant anxiety bubbling everywhere you go. I think the level of moral distress that the staff is feeling is far more intense than anything they've experienced before. Sharing stories with colleagues about who had to be present at the bedside of a patient who was dying alone and having to hold that iPad so that this person could say goodbye to their family, without the ability to hold a hand or to touch each other. And then I think about the need for physical distancing, really removing one of the primary sources of comfort and solace we have, which is the ability to go to a colleague and, get a hug or, even a friend or a neighbor. And, for folks who live alone, they're really very isolated. And so, I think the intensity of emotion is far beyond anything that I've experienced before personally. In terms of how I'm navigating that, I think it's been a phased approach. The early phase was very much responding to whatever anybody needed in that moment. Some of the things I mentioned earlier, we need a PPE protocol, we need this, we need that. As things have sort of churned along and some rhythm of some kind has been established, really triaging the requests that come in by just talking to people and really trying to understand, well, what is the problem you're trying to solve? and try and offer them some alternative solutions, because everybody thinks that a video is the best solution to absolutely everything in the world. But we can't put all those people in a room, and I can't bring in a video crew, and we don't have any PPE to use in a video anyway. And so let's think about, maybe something else that we could do instead. And thankfully, at this point where I am now, I think we have just hit our peak and are hopefully starting to see the other side of the curve. And I think our biggest role now is going to be preparing the organization to really do a very comprehensive debriefing. I mean, I think the amount of learning that has occurred in the past 6 weeks is enormous and pretty amazing if you really stop and think about it. And I think it's essential that we capture it and save it and use it in a way that puts us in a better situation the next time something comes along.
Great, thank you so much, Stephanie. I have a question for Lennox. Can you please discuss how your leadership of an overall health system has changed with COVID? It's a long question, I'm sorry, and how you've handled the dissemination of information. Maybe has your system changed how it communicates with employees? Because we've heard a lot have kind of communication fatigue.
So I thought I'd tackle this with sort of 3 really short anecdotes. So one of the things that I do outside of my immediate CMO duties is I lead a table of CMOs across Toronto. There's an organization that brings together all the academic hospitals across Toronto, and I'm the clinical co-chair for that committee. And this was a committee that met once a month, really discussing high-level things that affected the whole entire system as related to learners and clinical care and things like that. And if you rewind to about December of 2019, that's when we first started hearing early reports of the novel coronavirus out of China. And for the most part, it was, people go, oh, that's interesting. It's a little bit different. We'll keep our eye on this. By mid-January, I think there was a little bit more of an awareness of this. And we at Sick Kids have been testing for a while, and at a few other centers have been testing for a while. And the very first case of COVID appeared, I think in the 3rd week of January at an adult hospital. And that case was linked directly to travel to Wuhan. So this table that I lead, we got together, we thought, this would be a good time, a good idea to start sharing what we're doing, formalize some structures, pull together some joint communication, something that could be disseminated across the multi-hospital system all across Toronto. And so our bosses passed. So the CEO said, that's all right, we're good. 1 week later, we've now had feedback around inconsistent PPE practices. There was a bit of unease, hints of PTSD for those who were involved in SARS, because Toronto was the epicenter for SARS. So approached the CEOs again, and they said, no, we're good. It's all right. End of January is when the WHO declares it a public health emergency of international concern. And then 2 weeks later, we had an in-person meeting with the CEOs, again, flagging this and saying, don't you think we ought to do a little bit more here? And again, it was a pass. So, usually it's 3 strikes, you're out. So we said, all right, well, I guess this isn't going to be the route to things. March 11th is when the pandemic was declared. Between the sort of mid-February and mid-March period, we just started meeting as a group and started preparing as a group. And then on the 20th of March, the Toronto group, based on the direction of the CEO, said, all right, we've got to pull together an official pandemic operations committee, and everything all started falling together. And then my role then ended up being the co-lead for the physician response across the greater Toronto organizations, which expand beyond the academic organizations. So I think one of my lessons from this is that timing is everything when it comes to engagement with the C-suite and with CEOs. And the reality is we simply weren't ready. We weren't really ready to address and pull together the organizations. And that, I think in retrospect, you think about how the world was ready, large parts of the world weren't ready, as evidenced by the continued devastation that COVID's wreaked. So that's sort of anecdote one. Second anecdote, for those who aren't familiar with March break in the Canadian context, March break is sort of like Thanksgiving plus for those who have kids. It's one of 2 weeks in March where all the kids are off from school. Everybody has made plans for travel, and it's sort of a big deal. So March break this year was the week of March 16th. We'd been watching the COVID outbreak for a while, and I'd have a small group of people pulled together at the hospital level, and I said, we're going to have to put something out about this. We're going to have to make a decision. And on March 4th, I sent out an email with our head of HR to everybody in the organization and said, we discourage all non-essential travel outside of Canada. Travel may be disrupted. You might be in quarantine, really, and it was a bit longer than that. I was not a popular person after that email, and the email made its rounds all outside of sick kids. I had texts from people at other hospitals saying, hey, people were commenting about this. There's no way you wrote this, right? I said, no, actually, I did send out this email. And what happened is on March 11th, the pandemic was declared. And suddenly it became, wow, you had some inside information. March 13th, I sent out a follow-up email where I said, in light of the increasing travel restrictions, we're asking you to outright cancel or reschedule all out-of-country travel. And I actually responded to a lot of people saying, yeah, if you're already abroad, you should really make plans to come back. And then March 21st, the borders closed. Our Prime Minister made a call saying, everybody who's out, it's time to come home. So, my lesson from this was sort of that perfect is the enemy of good lesson. And there was an epidemiologist who said, it's better to be mostly right and early versus precisely right 100% of the time. Because you can only be precisely right in retrospect. And so that's, again, it's a question of timing. And had we waited a lot longer, I think we would have been in a much more poor position as an organization. So that's number two. And then the third one is a bit shorter, and it's sort of my reflection on communication in general to a broad group of staff. And so we went live with Epic a few years ago. And part of our big bang go live with Epic, and this was the biggest transformation ever in the history of Sick Kids. We had regular division head meetings, we had regular email communications, or large open forums. And these regular division head meetings that I held were pretty sparsely attended. I mean, I'd be lucky if I get a dozen people showing up to this. The staff forums, relatively well attended, maybe around 200 people at a time, but they weren't frontline people. And in spite of that, we still had a successful launch. Now, fast forward to COVID, and we now have audiences of 1,000 to 3,000 people on a regular basis. The physician leader meetings that I have on a regular basis have upwards of 40 individuals, always there, always with a lot of attention. And so my reflection on this is, again, timing. It's, timing matters in terms of availability of people. It matters in terms of what's enabled from a tech standpoint, and that attention of individuals also relies on timing as well. So, hopefully that gives you a bit of a flavor of how things are different. I never really imagined, even a year ago, that we'd be having these large town halls with over 1,000 people, some cases up to 3,000 plus people all at once tuning in. It's a very different world that we live in terms of communication. And part of it also is communicating outside of your immediate borders. So we're regularly in communication with people across Ontario, across Canada, and then across the US, and also to Europe as well. And part of it's a bit of a new world. And so a lot of this, I think, will inform how we do our work in the future, including simulation.
Great, thank you so much. I have a couple other wrap-up questions to ask you all, and then we have some questions that have been posed in the Q&A that we can get to from the attendees as well. So given all that we've shared, what are the upcoming challenges and what do you expect to stick around from a simulation perspective that you've learned? Because you've shared quite a lot of things that you've learned. And then I think it was Stephanie that mentioned what will the debrief process look like once we're hopefully on the other end of this for employees?
I mean, in terms of upcoming challenges, I think for me, what I worry about most is the mental health of the work staff. I think the amount of anxiety and stress that people are going through right now is overwhelming. And I think that a lot of the way they are getting through it is that they're just putting their heads down and working. And, you know, I have a lot of concern about what happens when they actually have a chance to stop and take a breath and really think about what they just did and what impact that's going to have. And so I, at least at our center, I know we do a lot of training around empathetic communication. And I think that that's probably going to be more important than it has ever been. But on an up note, let me just add a positive comment because that was kind of a Debbie Downer. Our executive leadership team has been doing weekly town halls with the whole organization. And last week, our chief clinical officer shared a slide that showed that across the board, all departments, our patient satisfaction scores for the past month are the highest that they have ever been. And they are all above thresholds. And that's in the wake of people having to be in the hospital with no visitors. And so when you really stop about and think about what that means and what the whole work team has done to be able to pull together and keep their eye on the ball, which is making sure that these people get taken care of in a compassionate and caring way under the current circumstances, I think that that's remarkable. And so my most sincere hope is that that sticks around.
I had two thoughts around, well, one thought around how things will be challenging and different, and then also I'll speak to Ellen's question in the Q&A too. So one, I think one of the challenges for anybody involved in anything academic right now is what does the post-COVID academic world look like? And, you know, and especially for, you know, things that are near and dear to my heart, like simulation and smaller societies like IPSS, I'm hearing from very large societies and very large organizations that travel and support for a lot of this work that has been going on before will be very, very different. I'm hearing this for major research organizations that it's a real concern. And so I think that's one thing that we would have to keep our eye on. And to me, this sort of pushes the connection between simulation and direct patient care and safety in a much more accelerated manner. And I think that leads to my thought around ideas for new paradigms for simulation. So, you know, maybe I can best exemplify it with some of the work I do really in a very narrow sense related to COVID. And one of the groups internally in the hospital that I work with deals with the regular changes in PPE. And basically every single day there is some look at how much inventory we have, what people use in various areas. We try and match that to supply. We try and match practice patterns to the changing guidelines that happen at a ministry level that are informed by science, that are informed by anxiety. And it's every single day. And so oftentimes I'm finding through the course of the week, there's going to be something or another that needs to rapidly get rolled out from between the hours of 11 till 4. And to be able to do that is really challenging if you think about traditional simulation approaches of, well, let's figure out our learning objectives, let's come up with the curriculum, we're going to test this, we're going to do that. So, you know, I think and it's not to say that all of simulation should shift this way, but I do think there's a chunk of simulation that needs to shift in a way that if you said, all right, I need you to look into this, within 40 minutes, it's all done. wrapped up from head to toe. And that's not been our traditional way of doing things with sim.
No, and in fact, Lennox was, I think Friday, it was me in my office with my human factors person and me getting in and out of a set of coveralls as we figured out what the protocol was going to be that needed to be ready by noon. You know, no video, no nothing. Let's just figure out how to get people in and out of this thing safely and go for it. So totally agree.
Yeah, I would say that traditionally, I really like things to go sequentially. I like to develop a process, test it, and then train to it. But with COVID, we lost that luxury of time. You know, while we were trying to fine tune best processes, our colleagues were potentially being exposed around the clock. And so one of the things that I think it really drove us to do, because it made us uncomfortable and put us in this learning space where we were really pushed to try things that we hadn't really worked out all the fine details, was to really experiment with simulation training and what that could look like, which was very different than maybe my standard menu was prior to that, you know, and get the feedback in real time and be okay and willing to deal with that. So do a Zoom sim where there were observers that would participate remotely in the debrief. Create a 5-minute sim that we could incorporate into clinical shifts that could train people. Create a drop-in sim room in the ED because our volumes actually did go down, so we did have one extra room where people could actually do self-guided sim on their own. So I think that's what I'm really hoping will carry forward, is that innovation, that challenge, all the different things that people have been trying all around the world, sharing that and really thinking of just new, different ways to use sim as the environment that we're training in has totally changed.
I think that all these examples just show how like nimble simulation is, how many different ways it can be used, and how, you know, there's not just one set proper way. I hope that given all the collaboration, both within the institution and across institutions that has happened, that continues and sticks around. And I also think that that this has been a great example for hospital leadership to see firsthand that power of collaboration with your SIM program. So hopefully that if you don't already have a seat at the table, that you can have that seat at your hospital's patient quality safety table. So.
Great, thank you all. I have to echo what was said in the chat during this from Kim Stone. Rapid response sim, it seems to summarize what you guys are all talking about, this paradigm shift. So I'm going to go to our questions from the attendees, and I see that Lennox, you answered Ellen's. I'm just going to kind of go down the list. So one from James is, how did you balance training? How did you balance training your staff to work together in a new resuscitation system versus simultaneously using SIM for systems design and engineering processes? So it sounds, you've all talked about that. So whoever wants to chime in, how did you balance it all?
Well, it couldn't be first come, first serve, I guess. So yeah, I think you looked at, so at least for our health system, we're across the whole state, and the spread of the disease really went directionally. And so, you had much different levels of acuity at various sites and had to sort of work with what was most urgent first, but then the benefit of that is that you could then sort of spread the learnings to the other institutions without having to do the same process five or six times. And so I think, that's where the communication piece really becomes essential, is, well, how do you get, your work product disseminated to 30,000 employees and get it where it needs to go? And so we ended up working very closely with our marketing department, who has been really managing and doing a wonderful job of managing our COVID resource page. And I will say that I was very impressed with them because they made this decision to make that page public facing so that there were no issues with firewalls across any of the hospitals. And, you know, I had put together a number of clinical resources for just-in-time training for around things like mechanical ventilation and different procedures. And a lot of what I had put together were YouTube videos. And so I said, you know, do we really want to put these YouTube videos on our public-facing page? And the senior team was like, yeah, we're good. This is fine. We're not alone. We're getting it done. You're providing what they need. And we're not worried about that. And so, you know, I think finding the right partners to disseminate your work and get it where it needs to go so you don't have to do everything multiple times is helpful in terms of scale.
Yeah, you should share those YouTube links with everyone so we can, I'm sure all of us would use them.
I'd be happy to send them out. The New England Journal has some fabulous procedural videos.
Great.
I think one of the things that I would say is that having really effective smaller teams that are already independently working on things is really helpful. So we had already had an amazing group working on Code Blues and Resuscitation and Code Orange work all across, and they just sort of instantly pivoted towards protected Code Blue work. And what you then need is somebody to connect the dots. So knowing that this body of work was happening, connected to this whatever's happening centrally, and then ensuring that that dissemination takes place, rather than necessarily having a central command and control of what each group is working on.
Yeah, I think that's a great point, Lennox. You know, we've been working under a hospital system incident command structure for probably 7 or 8 weeks now. And that's ultimately where all the information flows in and out of. And I think that definitely, you know, keeps things a little bit more organized.
Well, I'd like to move to another question from the chat. Suzanne Nelson asked if anyone could speak to any learnings or education that you did to prepare pediatric healthcare staff to care for adults. And I know, Tenzing, you spoke a little bit to, or maybe I'm getting it mixed up, but someone spoke a little bit to this, you know, how do we ready for adults? But just wondering if there's any guidance from you guys on that.
Well, I think I might be the only one who isn't in a freestanding children's hospital. So, you know, I think the organization approached it in a few different ways. Initially, what they did try to do was send the quote unquote young adults to the pediatric spaces. And so the original goal was to try and keep the under 40 crowd, you know, cohorting them to the pediatric units. That sort of quickly went out the window when beds were full. At least our PDICU, I don't think had any much older patients, but I know one of our pediatric surgical floors became an adult COVID unit and was staffed by pediatric nurses who just rose to the occasion. Our centralized nursing education department, with whom my program works on a daily basis, did an amazing job pulling together some virtual training sessions. And, you know, basically they spent 3 weeks doing just in time training for pretty much everything. And I think the key is the ability to really be collaborative and be a team. You know, knowing that you can call your adult colleagues if you have a question, but also, you know, having the pediatricians there to support and help take care of these 65-year-olds. But, you know, they somehow rose to the occasion and got it done. But lots and lots of just-in-time training around the basics.
Thank you.
We haven't done this at Sick Kids, but I've had conversations with a colleague, Pete Silver, who's the CMO at Cohen Children's, and they've deployed, I think it's 2 full teams to staff an adult ICU. So out of their ICU group, and others they've just gone over, and there's entire adult ICUs staffed by them. And my understanding of how it works is exactly as what Stephanie has said around just-in-time training. It was not the time to prep for a really long time and then get really up to speed in terms of, you just jumped right in there. There might have been a resource, a subject matter resource. And it sort of, to me, speaks to that different paradigm. You're not necessarily going to use mannequin-based simulation, but if you had the adult intensivist as well as the pediatric intensivist equally versed in debriefing, in communication, and all of the techniques of simulation, I got to think that that's going to be a better way of doing things. And so, having that sort of nimbleness to adjust, to teach on the fly in real life clinical situations, and applying a lot of the principles and theories from simulation in that context is critical.
Thank you. All right, let's go to our next question. I have a question that is, the requirement for social distancing is clearly a challenge in providing simulation education. So what solutions might you guys suggest?
I think this is where we as a community of simulationists and educators really have the opportunity to go crazy. I mean, things that felt like, I never would have thought that I would have 5 people in a room doing a sim, and this was a little bit earlier before we were on as strict stay-at-home orders, doing a sim and having 50 anesthesiologists watching from home and then participating in the debrief. I never would have thought of us using simulation to make the little video demo clips to be training our folks. I never would have thought that they would give us space in our ED to set up a drop-in sim center, and we created basically a guideline for how people could do sim on their own when they came in to do a shift. And I know that people are doing so many other different and crazy and great things. And I think that is really what has to happen, is we really have to think about ways to shrink down the amount of sim, find a way to stretch across the distance and the inability to get those large interprofessional groups together the way I might have loved. But now, we can't do it quite that way anymore.
Yeah, we also did a fair amount of virtual simulation, and then we set up rooms in the center for specific skills. So we had a glide scope intubation room, central line room, and by putting the instructor into the control room, you were able to, keep people sufficiently separated in order to get the job done. Certainly not ideal. I mean, there's some things that just require some hands-on interaction, but as Jen said, it's an opportunity to get creative. So.
Great. Well, thank you all. Let's go to the next one. So are there any restrictions being placed on the simulations in your organizations as you slowly ramp back to a new normal, for anybody that is ramping up to a new normal? And what will be different for your sim teams given these things?
Yeah, so this is something that I spend a lot of time thinking about now, and I've charged the rest of my team to start thinking about as well. Before all this happened, we do a lot of the new nurse hire onboarding in our center, and during the summer months, it's not uncommon for those groups to be 40 people. And so clearly, that's probably not going to happen anytime very soon. And so, thinking about, do we distribute them across multiple rooms? What pieces can remain virtual? Because our entire new employee orientation process is now virtual, which is sort of a remarkable thing that happened overnight because it had to. And so which pieces of that can remain virtual? How do we physically distribute people adequately and still ensure that they're getting the education they need? And sort of what gets priority in terms of using the space, since you're probably going to have probably literally about 20% of the physical space that you're used to having once you factor in the need to space people out. So we're sort of in that recovery planning phase now. So if anybody has any brilliant ideas, please let me know.
No, but I think that's where we're all starting to brainstorm now, because I think as an institution, we've at Seattle Children's, they've already, concluded that sort of the annual nursing training requirements, which is really what gets everybody to our large interprofessional SIMs, are being suspended for the rest of 2020. And I don't foresee, those large gatherings like Stephanie's talking about happening anytime in the next year. And so we are going to have to pivot and find something else.
Thank you. Yes, so kind of in that vein, there's a question from Trish Wood around Zoom Sim. I think, Jen, you had spoken about it. Could you give a little bit more background on how that would work?
So I know that people are on different types of Zoom Sims. The version that we did was really get people together in a room, and we basically had them doing the same. They were the participants, allow anybody who was in Zoom to be in if they were in the back of the room, and then join us debrief, so they could come and ask questions and we could talk things through, which gave them an opportunity as if they had been there as an observer. But I know that a bunch of you have all doing Zoom Sim all over the place.
On a related note, I'd love to see somebody do some work on attention and team dynamics and all these other things with when you have Zoom versus something else. And my personal observation is that certain meetings run way better than they ever could have on Zoom, because especially if you've got the right mix of people and everybody turns on their cameras, you suddenly can read an entire room full of expressions fairly quickly, versus the need to focus directly on one another. But then conversely, if everybody's camera is off and you don't have that insight, then you get all the downsides of it as well. So it'd be really interesting to see how this applies in a learning simulation context.
Yeah, we actually taught our faculty development, our intro to simulation course via Zoom for the first time a couple of weeks back. And I have to say the team was very pleasantly surprised with how well it went. Obviously couldn't do the full shebang, but they got a good chunk of it done. And the reviews we got were pretty positive. And so, I think that the opportunity does exist to get creative there as well. And given the need for people to, have debriefing skills at the current moment, I think that, it's important that we keep trying to teach that piece of it to as many people as we can.
I agree. So I want to be mindful of time. I do have one more question that's open on the Q&A that I would like to pose to the group, but we'll wrap up. How are you quantifying the resources or learner hours of these modified SIMs, especially ones that are self-guided? Any guidance on that?
Honestly, I haven't been.
No.
Probably would have been a really good idea, but I didn't think of it at the time.
You're just meeting the needs, right? Yeah. But a good thought. Oh.
Yeah, so we haven't either. And the interesting thing is the government's released a framework for compensating education hours related to COVID for physicians in particular. And it's one of these things that I find myself in discussions around all the time when it comes to things like simulation. We tend to jump in there, do the work without necessarily thinking about the dollars and the drivers behind it. And this was one example of that. So we haven't quantified it at all. And we're going to try and go backwards and maybe see if we can pull some numbers out of this, but it would have been a good idea in retrospect.
Right, it's a challenge. Okay, I've been alerted to one question that was missed. This was regarding one of the biggest challenges during this pandemic, kind of have a COVID fixation that blurs our diagnostic, clinical, and human factors skills for patients with non-COVID pathology. So how could simulation education help us in that situation? Any thoughts?
I don't have any bright ideas for that. I mean, what I'm finding is that COVID has consumed everything. Like when you think about, I'm guessing if any of you are like me, you look at your media feed, your social media feed, what you talk about at work, what people are worried about, what the parents are talking about. Every single aspect of what we're doing has so consumed the attention span of people that it's hard to shift that a little bit. The question in some ways answers itself in that clearly we need to have some way of ensuring that we don't forget the bread and butter and everything else that happens. But I don't have an easy answer to the how.
Yeah, I agree with Lennox, and that I don't think there are easy answers. We are fixated on COVID, and I think as simulationists, it is going to require our vigilance to keep asking the questions as we develop all these new processes and new tools to help prevent COVID, that we're also asking the question of what are the other unintended consequences and what are the impacts that adding on 2 more HEPA filters to the system are having on actually being able to effectively ventilate kids. So I think just keeping in mind that we should always be asking the flip question as well, and that what other things are we missing because we're focused so much on this one piece.
It was interesting. One of our senior executives shared the other day that the number of patients coming in with acute cardiac events has plummeted. And he's very concerned that they are just coming in much later because they don't want to come to the hospital. And so his big message was, we are here for people who are sick, not just people who have COVID. And, if you have chest pain, you really should come in because we can still take care of you. And so, I think that that's been true for stroke patients as well. The numbers have really gone down, and it's just hard to imagine that the cases have just stopped, but people are just not seeking care in a timely way.
One thought I do have is, perhaps ties into the question directed at me around communication is, so how does simulation tie into broader communication so that it occupies a greater proportion of your consciousness? And, if you think about how do people start thinking about different things, like, so a simulation is generally like a really short, defined period of time. A lot of times we forget about it not too long afterwards, unless there was something particularly traumatic or amazing that happened during that simulation. And where we might want to think about is, so how does it become not this really tightly constrained thing, and it's something a bit broader? When I think about how do you get things on people's consciousness, you kind of have to take a multi-pronged approach, and it's not just one form of communication, it's multi-pronged communication. It's not just internal, it's external. And the concept of missing something or delaying something because of COVID is a very real entity. And our efforts around this, just as an organization, has been to try and get at it through the media, in addition to our social media outlets, in addition to internally amongst the healthcare professionals. I'm not sure that it's really a huge thing amongst healthcare professionals. I worried about it a lot more amongst the general public. And just today, there was a news story out where I think it's within Ontario, there have been 35 deaths from delayed cardiac surgery in adults as a direct result of COVID. And we're certainly seeing other effects hitting kids too. And so I think time will tell. There's a growing literature around this. And my suspicion is that the solution lies less at the healthcare level, sector level, and more at a broader public level.
Great. Well, knowing that we only have a couple minutes left, I just want to thank you guys for taking the time today to share your experiences during this very uncertain time, as our leadership shared. And I also, because Isabel will appreciate this, just want to remind people to fill out the survey. The link has been posted many times in the chat if you haven't already done so. And really just thank you to each and every one of you for attending and for your great questions. So with that, I'll hand it back to Lydia.
So thank you so much. I'd just like to add to that thank you to all of our panelists, to our meeting organizing committee, and everyone else that's been involved with making this virtual meeting happen today. Thank you for your commitment to IPSS and for attending the meeting and contributing. I've honestly been blown away by the connection that I've felt to everyone here today. And I think a lot of that is about shared experience and recognizing that we've all been fighting a similar battle, if you want to use that analogy, over these weeks, and that we've learned so much and there's so much more to learn. We're really optimistic about being together in October, but please know that we do continue to monitor things closely, and we will make decisions which are safe for the society and for you as its members. In the meantime, please continue to register for IPSSW in October in St. Petersburg, to connect through virtual forums, and to watch for information from the society about other ways to get involved. Your support of each other through this community makes it what it is. Thank you so much, and have a good day or night wherever you are. Thank you.